Morning, everyone. So I'm going to make the case as to why it's not yet prime time for adjuvant EGFR-directed therapy for early stage non-small cell lung cancer. I will admit these drugs are awesome. Okay, on the left there is erlotinib in EGFR mutant patients, crizotinib in ALK mutant lung cancer patients, vemurafenib in BRAF mutant melanoma. These drugs are fantastically active and are certainly more active than our chemotherapies. And we want these kinds of drugs for all of our patients with advanced disease. Okay, these are the waterfall plots. They're fantastic, and they all look about the same, right? But that doesn't mean necessarily that they are curative. That's the question we're asking in the adjuvant setting. A couple studies have now looked at neoadjuvant TKI therapy for lung cancer to see if giving it before surgery leaves you with a cured tumor in your hand, a complete pathologic response. And I'll say that two published series from Canada and from Memorial Sloan Kettering had no pathologic responses. This is the one series that did report pathologic complete response from the Netherlands. 60 clinically selected patients, 27% had a PET response, 5% had more than 95% tumor necrosis, meaning in the end in their hand it looked like there was no tumor left behind, suggesting maybe they were cured, though they did not publish any data on whether those patients recurred or not, and some would argue 95% tumor necrosis should be 100% tumor necrosis if you're really going to cure a cancer. I think the jury is out whether TKI given for 3 weeks before surgery can really make a tumor cured. I will bring up this slide also to say that in this adjuvant imatinib data, it was not a curative therapy, right? The survival did not change. The patients who received adjuvant imatinib all ended up recurring, and the patients who didn't just ended up receiving the drug at recurrence and therefore had a great salvage therapy waiting for them. What you'll see is that, I don't know if I have a pointer here, that there are 60 to 70% of patients here who got no benefit at all from their 1 year of imatinib. Not a well-tolerated drug. This drug has side effects. A year of imatinib with no benefit. And the question is, should we give drugs in this setting, an optional setting where there is toxicity from durable therapy, but no necessarily change in survival? So maybe these drugs arrest growth, but do not in fact eradicate micrometastases, which is what we want from an adjuvant drug. Can TKIs cause harm in the post-op setting? This is the SQUAG experience. These are unselected patients, 243 with unresectable stage 3. They received EP 50/50 followed by consolidation docetaxel, a regimen, mind you, that we don't use anymore because we know it's worse than conventional EP 50/50 alone because that consolidation docetaxel actually worsens outcomes. What we found surprisingly is those that received gefitinib, the blue line, had a worse outcome compared to those that received placebo. This was somewhat startling data. Why is TKI making people die faster in the post-chemo RT setting? It's only a trend here. It's more striking in time to progression. And this was a bit of a wake-up call. Wait, these drugs can perhaps cause harm, so let's make sure we know how to give them before we give them in this curative setting. So the BR19 trial was supposed to be the arbiter that would help us make up our mind on this. This is a Canadian study, was presented 3 years ago at ASCO, and now, by the way, 3 years later has not yet been published, which frustrates me because I want to see this data in published form. 503 patients with resected non-small cell lung cancer received adjuvant gefitinib times 2 years versus placebo times 2 years, but the study was halted 8 years ago in 2005 because of that adjuvant SWOG experience. And so the arms were unblinded and patients were released to standard care. I will point out the arms were well balanced for performance status, stage, and receipt of adjuvant chemotherapy. Only 17% of patients receive adjuvant chemotherapy because adjuvant chemo became the standard of care as this trial was underway. So it does not really represent our current standard of care. But because it was halted early, only 5 months of treatment on study ended up being given before patients were unblinded. What can we learn from this? Well, this was the somewhat surprising survival data. No difference in survival, but perhaps a trend, again, favoring placebo over gefitinib. No difference in disease-free survival, but perhaps a trend favoring placebo over gefitinib, somewhat consistent with the SWOG data. And the most surprising was this data, that in EGFR mutant patients, which were 21% of the population, actually a kind of surprisingly high proportion for an unselected Canadian population, and I wonder if that is true. Again, we have to see the published experience. Placebo ended up being similar to gefitinib in the wild-type arm, but in the EGFR mutant population, surprisingly, the placebo arm had a better survival than the gefitinib arm, p equals 0.16, so not statistically different. But this gives us pause to say, wait a second, what are these drugs doing in the adjuvant setting, and should we be giving them? The data on disease-free survival was not reported, and so again, we need to see the published experience to really learn from this. But how do we explain the possibility that adjuvant TKI could make survival worse in this population? Is it due to toxicity? Are we causing severe diarrhea and severe rash so people are dying faster? Probably not, and that was not the finding in the data so far. Is there accelerated development of resistance? I actually don't think so, though some hypothesize that. I'll present some data as to why I don't think that's the case. Was this a statistical fluke? I mean, that's possible. This was not statistically different. One thing I worry about is there may have been suboptimal management after recurrence. How do you manage a patient who recurs after receiving adjuvant erlotinib or gefitinib? This was an experience that I published when I was still at Memorial Sloan Kettering. We looked at 22 patients with EGFR mutant lung cancer that recurred after receiving adjuvant TKI on that experience that Dr. Rizzoli just presented. 11 of these patients were retreated with TKI. So they got adjuvant erlotinib or gefitinib, they recurred, and then they got it again. And what do you know? 8 of them responded. You can respond to this drug a second time, sometimes durably, with a time to progression of 10 months. So patients can receive the adjuvant drug, can then recur, can receive the drug again at advanced disease, suggesting that retreatment may be a strategy for maximizing survival from these therapies. If you look back at the BR19 arm, if you got surgery and then gefitinib for 5 months and you recurred, do you think you were getting erlotinib or gefitinib again at recurrence back in like 2008 or something? No, we weren't really doing that. These people weren't genotyped. But if you were on the placebo arm and got placebo for 5 months and then recurred, did you get TKI, erlotinib or gefitinib at recurrence? Yeah, we were all excited. 07, 08, everyone was getting erlotinib, gefitinib, especially non-smokers, right? So maybe the placebo arm got more TKI than the gefitinib arm did. We're not sure. And that's why we just don't know enough about this therapy yet to use it. Do you retreat at recurrence if you give adjuvant TKI? I think it needs to be studied prospectively. What duration of adjuvant TKI should you use? Is this like 4 to 6 months like adjuvant chemo? Is it 5 to 10 years like adjuvant tamoxifen? Or 1 to 2 years to 3 years sort of randomly pulled out of nowhere? I don't know. Actually, Dr. Rizzoli has a study testing this to randomize 6 months versus 2 years of adjuvant afatinib, because we don't know how long you're supposed to give these drugs, if at all. What stage of lung cancers? Is it like in GIST, where you just treat the highest risk stage 3 type thing? Or is it like with tamoxifen, where you can treat a stage 1 using an oncotype DX? We don't know. Can you give it after radiation? There's a lot that we don't know yet if we're going to be doing this safely for our patients. We need a clinical trial. That clinical trial is not the RADIANT study, I'm sorry to say, okay? The RADIANT study is 945 patients, EGFR positive by IHC or FISH, so biomarker selected but not mutant, mind you. 2 years of erlotinib, again, a number sort of pulled out of nowhere versus placebo. Accrual has been completed. We expect results soon, but is this trial going to give any clear answers? I'm actually not sure. 12% of patients had EGFR mutations, 113 patients, probably not big enough to see a statistical difference. And most importantly, I'm worried that compliance with the study drug may be poor. Because this is an unselected patient population. The patients don't know they have EGFR mutations when they're getting acne and diarrhea for 2 years after surgery. Right? They just were told this drug might be good for you, and they're like, well, I heard it doesn't work for most patients, and I'm not sure I want to feel this crummy for 2 years. As opposed to if you say to the patient, you have an EGFR mutation, this drug is fantastic for you, take it and mean it. And so I'm worried this is not going to give us answers that we are looking for. And that's why I'm leading to this study, which is the Alchemist effort, led by the NCI, Adjuvant Lung Cancer Enrichment Marker Identification and Sequencing Trial. NCI came up with that. Pretty catchy. This is 8,000 resected lung cancers who are going to be screened over the course of 4 years for EGFR mutations and ALK mutations. So this is a heck of an undertaking. Those with EGFR mutations will go on adjuvant Alchemist EGFR, which randomized patients to erlotinib times 2 years versus placebo times 2 years, a study that will be led by Dr. Vinden, our host. The Alchemist ALK study will be randomized to crizotinib versus placebo, a study being led by David Gerber from UT Southwestern. And the patient's wild type for EGFR and ALK will go on an observation arm until time of recurrence, at which point they will then have genotyping done to lead to targeted therapies at recurrence. So this is going to be a big undertaking, hopefully finally answering the question as to, in genotype-selected populations, should you use these targeted therapies as opposed to placebo? So in summary, EGFR kinase inhibitors, yes, they deserve further study as adjuvant therapies for resected EGFR mutant non-small cell lung cancer, but the data right now is too suspect to conclusively use these for our patients routinely. And let's debate.
Thanks.